So tonight we're going to have dangers facing young athletes, coping with doping, discussions of concussions, and sudden cardiac arrest.
Well, I have the pleasure of introducing Dr. Rao. As you can see, he's the Clinical Associate Professor in Family Medicine here at UW. He's the Clinical Director of Hall Health, Sports Medicine, and serves as the team physician for the University of Washington Husky athletes and the Seahawks. My son will want to meet you. And as you can see here, he's really, really cold, but the coach is not. So special interests include musculoskeletal ultrasound-guided procedures, and he's involved in medical student and resident education, which I think is really important. He is such a great role model. And patient-centered care, injury care and prevention, and emergency preparedness. He's recently been honored by the American Medical Society for Sports Medicine with the Sports Medicine Recognition Award and the Henry Galanti Young Investigators Award, which recognizes the most outstanding research presentation by a sports medicine fellow. And you know what, I have to say, I need to point this out, which is that these are incredible, these are really incredible accomplishments for someone who is really so young and so relatively recent in finishing his fellowship. Because I do have to remind him that even though I have gray hair, it wasn't that long ago that he was a resident. He completed his undergraduate studies at Swarthmore, medical degree at Case Western Reserve, and completed his residency training in family medicine and sports medicine fellowship here at university, and we're happy that he's decided to stay and that we can offer him a job that he loves. Currently serves as clinical associate professor at the UW Department of Family Medicine and Hall Health Sports Medicine, and he is the chair of the University of Washington Sports Academic Conference Curriculum and on the research committee for the AMSSM. So with that, I'd like you to welcome, as I do, Dr. Rao.
Well, hi, everybody. It's really a great honor to be speaking in front of you at the university's mini medical school. As you guys know, I'm a primary care sports physician. My background training is in family medicine, which is how I know Edith, and I decided to subspecialize in sports medicine. Dr. Harmon, who you'll be hearing second, is one of my principal mentors, so you'll have a lot to learn from her and hopefully some to learn from me as well. The focus of my practice is the care of injured athletes, but I also care for athletes at the amateur level as well as through the pro level. And it's my charge today to speak to you about the topic of doping and performance-enhancing drugs. No recent discussion of this topic is complete without a mention of some of the athletes who have been centered about the discussion of that. Our most recent and possibly most dramatic example you guys are probably all aware of is Lance Armstrong, the recently disgraced 7-time Tour de France champion who was recently stripped of his titles, partly due to the fact that he was using performance-enhancing drugs during his performances and his career. I bring up Mr. Armstrong to illustrate some of the issues surrounding performance-enhancing drugs, including disclosure, and why this is such a difficult topic to address to one's family member. This might be your kid. As a physician, it's a challenging topic to discuss, and obviously from a media standpoint, it's interesting enough to talk about here today as well as in the national media. So, Mr. Armstrong, for nearly 13 years, he was quoted on many times on the record vehemently describing the use of performance-enhancing drugs, despite mounting evidence to the contrary. He actually had enough evidence leveled against him that the United States Anti-Doping Association decided to strip him of his tour titles, even before he had come out with his disclosure. I wanted to provide you a few of the quotes that he made over the years. In July of 1999, just about a year and a half after he had been successfully treated for metastatic testicular cancer, which was part of his inspiration for the Livestrong campaign that he led afterwards, he was quoted as saying, quote, "I've been on my deathbed, and I'm not stupid. I can emphatically say that I am not on drugs." Then in January of 2004, sort of mid-career when he was winning many of his championships, "I've never had a single positive doping test, and I do not take performance-enhancing drugs." Even more emphatically, in the face of mounting controversy in June of 2012, just 6 months before his disclosure, "I have never doped. I have competed as an endurance athlete for 25 years with no spike in performance, having passed more than 500 drug tests and never failed one." Mr. Armstrong's disclosure in January on the Oprah Winfrey Network was a complete about-face, obviously, of his prior vehement refusals to admit to using performance-enhancing drugs. Obviously, in our society, self-worth and success in athleticism are tied closely together, and I think athletes are often seen as pillars of physical fitness and beauty, as well as role model to our younger athletes. Sometimes they're put in positions where they feel that they can't disclose. Our athletes also put incredible amounts of pressure and identify winning as almost paramount to everything else. As an athletic culture, sporting is essentially celebrated on TV and the internet, and it furthers this sort of constant media coverage essentially solidifies athleticism in our own identities, in the identities of our youth athletes. I bring that up basically to at least consider why it is that individuals start using performance-enhancing drugs, because it has to begin somewhere. In some cases, a young athlete may feel that he needs to win, and he needs to be like his role model. Maybe he needs to simply be able to compete with other teammates, or maybe other teammates are using substances that he feels that, or she feels that he can't keep up with. And these substances may include performance-enhancing drugs aimed at improving performance. Further, the youth athlete is faced with many barriers to success, and they may just simply turn to performance-enhancing drugs to optimize their chances. One of the individuals who studied this question of winning against all costs was Bob Goldman, who was a researcher who, from 1982 to 1995, carried out a study where he effectively posed athletes with the scenario of whether or not they would succeed, what it would essentially take to succeed at the highest level. Essentially, he proposed a scenario in which an athlete would be offered the option of taking a substance that would guarantee a gold medal, but then in 5 years would result in death. And what that athlete, and then the athlete was asked whether or not they would take that substance. Over 50% of the athletes elected to say that they would take such a substance. So you can see what, as a physician or as a family member, you're up against when you're dealing with an athlete who puts that type of value on winning, and why they may turn to substances that the rest of us might not necessarily turn to. Interestingly, there was a study carried out recently asking that same question to people who are not athletes in Australia back in 2010, I believe, and only 2 out of 250 surveyed individuals said that they would take such a substance. So you can see there's a disparity there, and for athletes, it may be that winning or succeeding at all costs is something that's more real than it is to us. There's a variety of different sports-specific pressures that I wanted to bring about, coming from within, but there are also pressures that come from without, pressures coming from parents, from students that the athlete is competing with, sometimes from coaches, and these things can drive and put even more pressure on the athlete than they're already feeling themselves. Ultimately, some of these individuals feel that they're trying to level the playing field. You can even hear in some instances in Lance Armstrong's disclosures that he felt that he could not compete or win Tour de France championships without resorting to the use of performance-enhancing drugs, possibly because everybody in the lead pack was using such substances. So this brings up the question of what is fair play, and what are the pressures of selective advantage. So over the past 15 years, the media has done an incredible job covering various aspects of performance-enhancing drugs, and what is becoming clear is that performance-enhancing drugs have invaded multiple sports. Initially in the 1980s and 90s, you heard about this in the Olympic sports, but then in the early 2000s, increasing numbers of baseball athletes were identified as having potentially used and then ultimately disclosing the use of performance-enhancing drugs. But no sport has essentially been missed or has been not targeted. We see athletes in basketball, we see athletes obviously in cycling and even in football, all of who have been identified as using performance-enhancing drugs over the past 10 years. So out of this interesting increase in evaluation and from the media standpoint has grown the league's policy test for performance-enhancing drugs. And what you can see on this slide is essentially a wide variety of testing strategies employed by different professional and elite league organizations. Some institutions will test, for example, the NCAA will test twice a year, once during the regular season and once during the off season, although some colleges will test more frequently than that, but the NCAA will come in and test twice a year. In contrast, in sharp contrast all the way at the end, the International Olympic Committee will test randomly, unannounced, at any time with both blood and urine, which increases the sensitivity of testing. Most of the professional sports entities in the United States, including Major League Baseball, NFL, the NBA, and NHL, have various policies of testing, most of which use urine tests to try to identify performance-enhancing drugs. There are changes coming. You may have heard in recent news that Major League Baseball is in the process of approving in-season growth hormone testing, and that includes the test using blood tests to try to identify growth hormone. Urine may not be as sensitive as needed to test for growth hormone. And the NFL is also nearing this, but those deals have not yet been finalized. Penalties. One of the issues in trying to identify how to stop performance-enhancing drug use in sport is how we should level penalties against athletes who are identified as using. As you can see, different entities that I just mentioned before use a wide variety of different penalties to gauge and stop offenders. In terms of the NCAA, a first offense results in a 1-year ban, while a second offense results in a lifetime ban. The International Olympic Committee similarly uses a 2-year ban for a first offense from competition in Olympic sports and then a lifetime ban. In contrast, the NFL, a first offense results in a 4-game ban, followed by an 8-game ban, followed by a 12-month ban. So you can see there's a wide variety of spectra. NASCAR, in contrast, essentially says it's up to the NASCAR's discretion what type of suspension they decide to level. So there's a wide variety of penalties and some question as to whether those penalties are truly effective enough to dissuade athletes from using performance-enhancing drugs. So that statement there, I did not have access to anything else that nobody else did. So what does everybody have access to? Well, let's talk a little bit about that from a prevalence standpoint. What we do know is that performance-enhancing drugs appear to be used by at least 1 million Americans. In terms of professional or elite athletes, a 2001 survey of NCAA athletes suggested that as many as 3.5% of surveyed athletes had used growth hormone within the prior 12 months. A more recent 2011 youth risk behavioral surveillance study that's performed by the government to try to address youth high-risk behaviors reported that at least 3.6% of students, these are high school students, had taken steroid pills or shots without a doctor's prescription, with slightly more males than females. And in health club attendees, as many as 24% when surveyed used performance-enhancing drugs. It's pretty shocking. So what's being used? A wide variety of substances. I'm going to do a little bit more of a focus on anabolic steroids and growth hormone, but there are a variety of substances that are being used in many instances to try to improve performance, but for other reasons as well. Obviously, growth hormone and steroids have been implicated in increasing muscle mass and recovery, but there are agents that are used to try to mask the use of steroids. There are adjuncts to growth hormone and steroids that are used to try to supplement their effects. And there's a variety of other substances. Obviously, Lance Armstrong used blood doping, transfusions, and erythropoietin, amongst other things that he was using. And there are novel concepts that are on the horizon, using genes introduced via viral vectors to introduce genes that code for muscle proteins or substances that might increase performance. These are things that are out there. These are being discussed on the steroid forums, and unfortunately, they're a reality that we will have to deal with at some point or the other. So this is just another slide of how many different types of agents may play a role in performance, everything from stimulants that improve acuity and focus, to substances like growth hormone steroids that are aimed at building muscle mass, and then other substances that may mask drug use, reduce weight, improve oxygen delivery, or mask pain. Where we draw a line in terms of what we consider legal and what we consider illegal is not always as clear as it seems, because there are a variety of things we can use to adjust performance, and some of them are deemed to be illegal and not studied as appropriately as others. In 2006, the World Anti-Doping Association provided us with essentially a breakdown of what their positive tests, what they were identifying when they were actually testing positive athletes. And what it turns out in 2006 was that about 45% of agents were in some measure anabolic, that being testosterone or one of its derivatives. But as you can see, there were a wide variety of other positive tests. The World Anti-Doping Association is one of the leading groups to try to identify and set policies on testing for performance-enhancing drugs. And they're in the process of trying to identify testing policies like testosterone profiles or biologic passports, essentially aimed at trying to identify baseline levels for athletes so that when they test them again, if those levels are different, that could imply an athlete in using substances that may adjust their performance. So why do we care? Why do I care? Well, for what it's worth, it seems that performance-enhancing drugs have had some persisting use in athletics, at least in the recent past. And then there's always the emerging drug or emerging market for something new. Unfortunately, these substances have an unknown risk and benefit profile. These are not substances that are very rigorously tested. They're not regulated by the FDA, and they are they are banned and illegal, so they have a legal jurisdiction issue. They can confer a selective advantage, or at least we think that they can. And unfortunately, in my group, there's a relatively high abuse potential, so I have to pay attention to this. And obviously, with the media coverage, that always brings it to our attentions even more so. So as a provider, I think that it's important to identify that knowledge is power. I have made sure to try to get familiar with the terminology. And I think it's important to be able to connect with my patients to be able to affect any change at all. Knowing that performance-enhancing drug use is deep-seated and it's going to be hard to change the beliefs of the individual who may be using that. So my goals: identify the at-risk athlete and try to use a non-threatening approach, understanding that they may have perceptions of me as a healthcare provider as to what I might be able to offer them or what I may or may not know. My goal is to provide education within my own framework. Obviously, my knowledge is different than their knowledge, and I acknowledge that right up front. It's my attempt to try to address a disordered behavior if I see it as such, but recognize that this is a challenge and try to mitigate the challenges and see where I can go with it over time. So in order to know what's going on, I have to ask. I think it's easier for healthcare providers to simply avoid the issue, but I ask. And in order for a patient to confess, they must feel comfortable with me. And beyond that, it's important to just look for signs of injection or steroid or growth hormone use or other performance-enhancing drug use in terms of how a patient may look. That might mean that they've gained weight dramatically over time. They may have suddenly developed acne in their adulthood. There's a variety of different things to look for. It's important for me to try to empathize and avoid passing judgment. And that's a challenging thing to do as somebody who does not use performance-enhancing drugs, to be able to appeal to a user's sensibilities. I think it's important to try to address the underlying issue. You know, the use is probably the presenting problem, but oftentimes it's something else that underlies it. And is that body image? Is it performance? Is it a desire to compete that we had talked about before? Or is it simply physical enhancement? These are things that I think are important to discuss over time. I think it's also important to understand that users have specific attitudes about healthcare providers. Many healthcare providers are typically uninformed or minimally informed on this topic. And sometimes providers are viewed as less health conscious than users themselves. A user may come in and look at me and say, hey, gosh, you know, you don't look like the model of fitness, but, and that's fine. But at the same time, I have to try to address them at a level that they can understand and appeal, and that may not necessarily have anything to do with me. Users also rarely seek professional help for performance-enhancing drug-associated issues. Oftentimes when I've kind of taken a look at steroid forums, I'll see individuals asking others about side effects and how to curb or mitigate those side effects. There's a variety of quotes that you can find if you look around. I'll just give you one of them. Some doctors, quote, "cannot be persuaded to do anything. This is one of the reasons I stress finding the right doctor." And for individuals who are looking for substances like testosterone or growth hormone to be prescribed, obviously I'm not the right doctor, but they may be looking for different things. Sometimes they're just looking for a little bit of help. So as a provider, learning about this meant that I needed to educate myself. Some of the literature behind performance-enhancing drugs can be found in basic science and animal studies, but the fact of the matter is that large population-based studies, the type that I use to kind of render judgment based on whether or not something is safe or not, those aren't available for performance-enhancing drugs. There's a stigma of using these substances, so they're simply not studied in the way that other things are. So I have to be creative in trying to gain an understanding of the situation. So what have I learned? Well, what I've learned is that many of the studies that I've looked at that are of poor quality, in my opinion, are championed on the forums, and some of the side effects that are thought to be detrimental in my mind are considered beneficial. For example, growth hormone is known to cause carpal tunnel syndrome, and there are companies that market their products as very successful. If you start developing carpal tunnel symptoms, you got a good batch. So those are things to kind of keep in mind. Online reports may be very compelling, but there are just as many anecdotal positive reports as there are negative reports. And there's a language to the steroid culture that you have to become familiar with. For example, some of the terms that are out there, anabolic steroids often goes by the term, roids, sauce, juice. There's a variety of ways to kind of discuss steroids. Most users use performance-enhancing drugs in cycles. That means that they're using steroids alongside other supplements for specific periods of time. Performance-enhancing drugs can be used in either bulking or cutting cycles. Bulking cycles are aimed at trying to gain muscle mass, and then cutting cycles are aimed at reducing body fat and increasing tone. Individuals may stack multiple supplements together, so they may not just be using steroids and growth hormone, but they may be using substances like thyroid, insulin, a variety of other things like HCG, Arimidex, which is a cancer drug, and medications that help stimulate other things like fertility in order to curb side effects and to manage their use. So it's a complicated science without much science behind it. There's a variety of other languages that I listed there. Steroid users and growth hormone users are trying to avoid crashing. Essentially, when a steroid or performance-enhancing drug is discontinued, there's a dramatic loss in muscle mass and strength, and that's what's trying to be avoided. Rebounding essentially involves a technique of restoring endogenous testosterone production, that is your own testosterone production, and using some of these other agents that I've talked about to try to do that. So let's briefly talk about growth hormone. This is produced by the brain in the pituitary gland and is regulated through signals from higher up in the brain. And its primary functions in the body in normal individuals are to increase height during the growing years, as well as to promote blood sugar glucose availability. It also has functions in fat breakdown, increasing lean body mass, as well as organ growth. In excess, we see this in individuals who have growth hormone secreting tumors who may develop conditions such as acromegaly and gigantism. And in individuals who have growth hormone deficiency, they may stop growing as kids, something called pediatric growth arrest, or have dysfunctions in energy, bone mass, and strength modulation, which occurs in individuals with dwarfism, genetic conditions such as Turner syndrome, and certain types of kidney disease. The FDA only approves the use of growth hormone for on-label use for AIDS wasting syndrome, which we're seeing less and less with efforts to curb AIDS and HIV, as well as growth hormone deficiency, which I discussed may be related to some other medical conditions. From a recreational standpoint, growth hormones gained interest in the community as an anti-aging drug. It's aimed to improve and augment steroid use, and it's supposed to help with muscle building. It's purportedly used to increase lean muscle mass as well as to recover from injury. It's quite expensive, $400 to $500 a month to use growth hormone. And annual sales in the US top $2 billion via prescription, although the majority of use is off-label or non-prescription use. From a side effect profile, I talked a little bit about carpal tunnel syndrome, but there are a variety of other conditions like fluid retention, body aches and pains, which can actually curb and limit performance. Growth hormone has been implicated in promoting tumor propagation in some cases, leukemia and colon cancer, and it can stimulate insulin resistance and ultimately diabetes in individuals who use it inappropriately. In some individuals, it can cause thickening of the heart and ultimately cardiac instability and sudden cardiac arrest. So it's not necessarily a safe substance to use, especially when it's not monitored or regulated. So does it work for performance enhancement? Well, I think the jury is essentially still out there. What we do know is that in individuals with growth hormone deficiency, supplementing and normalizing growth hormone levels does increase blood sugar availability, oxygen delivery to muscles, and it essentially normalizes exercise capacity to individuals who don't have growth hormone deficiency. However, if you're healthy and you're already producing normal amounts of growth hormone, does supplementing with it with more have an effect? Well, it appears that at least in limited studies, these are not the best quality studies, but still, growth hormone does not appear to increase muscle protein synthesis or hypertrophy or muscle mass. It does not appear to improve exercise capacity or power output. It's interesting that it's been promoted as an anti-aging substance, but in animal studies where exogenous growth hormone was provided to animals at supraphysiologic doses, those animals' life cycles were actually shorter. So what about steroids? Anabolic steroids are derived from testosterone, which is a precursor to estrogen, and testosterone is actually derived from cholesterol. Doping tests have focused on evaluating testosterone testosterone to epitestosterone ratios, and testosterone derivatives are wide-ranging. It makes testing particularly difficult because the companies that are making this are always kind of tweaking their products, and it makes testing policies very, very difficult. Testers are always having to catch up to the individuals who are making these products. So in puberty, testosterone is responsible for the development of secondary sexual characteristics, growth, and development. And in adults, it may regulate a variety of processes, everything from muscle protein development to sexual function to blood cell production, and plasma levels of testosterone can vary quite widely. In general, females have about 10% of the circulating levels of males. So why do people use steroids? Well, medical indications of testosterone deficiency can be supplemented by steroids. So people are trying to use steroids to make up for things like hypogonadism, which is essentially a condition where the sex organs, like the testicles and ovaries, stop making sex hormones, and so providing testosterone can stimulate that. From a recreational standpoint, testosterone has also been used as an anti-aging and wellness drug, and it's likely able to increase muscle size and strength as well as lean body mass. For people who work out and for individuals who are trying to use it for performance gain, it may be able to protect muscles against muscle fiber damage related to exercise and improve exercise tolerance. That's been clearly shown in animal studies. The problem is that testosterone has a wide range of effects, and steroids have a wide range of side effects. Everything from heart instability and arrhythmias to skin changes, to the behavioral changes of mood swings that are implicated for certain types of products and not for others, libido changes and reduced fertility. You can see that testosterone, when used unregulated, has a wide range of concerning findings. A recent study looking at cognitive deficits have shown that in computerized neuropsychologic tests, it appears that steroids can cause problems in pattern recognition and visuospatial memory, which could actually have a role for athletes who are trying to perform at those levels. So I think it's important to understand the challenge of performance-enhancing drugs. And here are some of those challenges. I think most use is unregulated and unmonitored. That poses a particular concern to me, trying to take care of an individual's health when what they may be doing a lot of harm to themselves. Most of the regimens being used are not rigorously tested. They're essentially anecdotal reports of somebody who's created a regimen that seems to work for them and then gets popularized. Convincing science, as I mentioned, is not really available, at least in human studies. The benefits may be unpredictable, toxicity may be unpredictable, long-term side effects may be unpredictable, and unfortunately, our testing methods lack adequate sensitivity, and we're always playing catch-up. Performance-enhancing drugs are widely available. They're widely discussed on forums that are easily accessible on the internet. And users' beliefs are that traditional physicians can't help in most cases, which is a challenge. There's a lot of role modeling in the community itself, so individuals are talking to other users of performance-enhancing drugs to get their tips. And the goal for most people who are using performance-enhancing drugs are to improve performance, to try to normalize, and to repair. So what do we do as a community? I think this is a real challenge. Ultimately, I think it'd be ideal to promote a culture of fair play. The World Anti-Doping Association has a media campaign, essentially a picture I put on the right. I'm an athlete and I compete clean. So try to champion and support that type of venture would be an ideal way to kind of get at the problem. The question is anybody listening? It's also important to understand the effects of performance-enhancing drugs via more rigorous scientific study. Until we get our hands around this from a scientific standpoint, I won't really know how to counsel my patients on whether they're beneficial or not and what risks there are other than what we've already talked about. Ultimately, it would be nice to develop and employ more rigorous methods for testing so we can catch people more easily and ultimately identify, enforce more meaningful penalties, because if we don't find penalties that can curb use, people will continue to try to find a way. Ultimately, it'd be helpful to not just target the negative, that is, impose penalties, but try to remove motivation for using individuals from using these substances. Individuals such as Frank Thomas, who was a career .301 hitter for the White Sox, he was a successful first baseman who had a Hall of Fame career, stated, quote unquote, "These guys put up some incredible numbers, but they're fake. You look at the PED situation in Lance Armstrong, and it's serious out there. I'm thankful I did it the right way and had a good family base that made me outwork everybody else. Watching all the nonsense unfold makes me feel even more proud of my career." So I wanted to wrap up this part of the talk with a quote. This comes from Mr. Armstrong as well, that I think sums it up pretty nicely. Quote, "It's this myth, this perfect story, and it wasn't true." I think that summarizes where we are. There are a lot of falsehoods regarding performance-enhancing drugs and whether or not they work and whether or not you're sacrificing the short-term gains for long-term health. In the face of impacting legality and performance, doing so in using performance-enhancing drugs in the face of the bans that are potential and the legal consequences, on top of the unknown health consequences, to me is unacceptable on many levels. And I'd encourage individuals to consider that when they're using it. So, obviously, the topic of concussion has gained increasing exposure in the U.S. sports media, largely related to the attention provided through cases that have occurred in the National Football League, where I'm a team physician, as well as in collegiate sports. My goal is to introduce you to this topic and give a lead-in to Dr. Harmon's talk later about this. So what is concussion? Well, concussion, the actual word, derives from the Latin word concutere, which means to shake violently, and concussus, the action of striking together. So you can imagine to shake violently after striking together kind of gives you a good feel for what happens with concussion. The CDC defines this as brain injury that alters the way your brain functions. The American Medical Society, one of the premier sports medicine entities and governance bodies in the United States, has defined concussion as a traumatically induced transient disturbance of brain function caused by a complex pathophysiologic process. Well, whereas all head injury does not equal concussion, concussion is only a small subset of the different types of injuries that can occur to the brain. So I want you to think of the term mild traumatic brain injury, of which concussion is a subset. So this occurred on a Thursday night football broadcast about 2 years ago. You can see Mr. McCoy lying down. A flag has been thrown, and athletes are surrounding this individual, trying to get him up. You see that he's essentially unprotected, and there's the blow right there. There's a helmet-to-helmet blow. He's also suffered a second impact on landing on the ground. Here it is again. Helmet-to-helmet, head snaps back, and down he goes. It gives you a visual for what concussion is. So as an NFL team physician, I work in a group of several other physicians, 3 to 5 of us, as well as a group of athletic trainers. We all have various responsibilities on the sideline to attend to both injured athletes on the sideline as well as to pay attention to the game. I think the important thing is that when we're managing any game time situation and injury, it's important for one of us to always have our eyes on the field. I think it's very important to always be paying attention to what's going on in the field. And it's easy to be distracted when you have an injured athlete that you're trying to care for, to put all of your attention on that athlete. So what we do amongst our group is to decide when one injury occurs, some of the team will attend to that injured athlete, but the rest of us will continue to keep our eyes on the field. And the reason to do that is to pay attention to anybody who is a downed athlete on the field. Anyone who is on the ground and either not responsive or not getting up has to be suspected of having a catastrophic injury. One of the injuries that one has to suspect is concussion, but there are various other injuries, including injuries to the neck and spine, as well as cardiac arrest. Not all concussions are as obvious as the individual who's down and sort of knocked out. Any athlete who may have gotten injured in a scrum or in some other ways, it was not as easily identifiable, who comes off the field stumbling, might have to be considered at least for concussion. An individual who's overly emotional, where they normally are not emotional, should also be considered for having had a head injury. I think to know your athletes is key. If you do not know your athletes, it's hard to pass judgment on how they are when you're assessing them. They may have behavioral change and other subtleties into how they're behaving that may make it difficult to identify a concussion if you just don't know your athletes. So I think one of the important messages is that as a team physician, being present and spending time with your athletes helps with identifying and understanding concussion. Finally, I think it's important to have a rapid response. Anytime you're worried about an individual with a catastrophic injury, to respond quickly and definitively is key. As far as signs and symptoms of concussion, there are many signs and symptoms of concussion. What I'm looking for is individuals who appear to be different than normal. Maybe they have gotten knocked out on the sideline. They seem to have difficulties with balance. When I'm assessing them, they may have difficulties orienting themselves to the circumstance of the game. Questions like who's winning, who played last week may be difficult to answer. They may appear to have slurred speech or difficulty focusing. There's a wide variety of symptoms. They may, if they're willing to disclose that they have headaches, dizziness, or a variety of other symptoms, but one of the challenges is having athletes actually be upfront about their symptoms, because their desire is to return to play as soon as possible, and they may feel that if they disclose, that'll make it harder for them to get back. So sometimes you have to rely simply on your signs of how they may be looking different. So how often does concussion occur? Well, the CDC reports that as many as 3.8 million sports-related concussions occur in the US annually. About 9% of sports-related injury appears to be related to concussion, and 30% of cases occur in youth sports. We celebrate and talk about the cases that occur in professional sports, but the fact of the matter is these occur a lot more commonly in our younger athletes. It appears that concussion occurs more commonly during competition as compared to practice, and interestingly, in comparative sports like soccer played by both men and women, there appears to be an increased incidence of concussion in females. It's also important to understand that the incidence is likely underestimated because athletes often fail to disclose or understand their own symptoms. So what do we do in the NFL? Well, basically in the NFL, we try to understand and see where our athletes are before the season even begins by performing a baseline test. This test includes a test that's one-on-one between the physician and the player going through a set of comprehensive concussion tests, and in some cases there's an additional computerized test that's employed. The next time you may see an athlete for this particular issue may be immediately after an injury where you suspect that they have a concussion. That test occurs on the sideline typically when they've been pulled off the field. If there's any suspicion that an athlete might have concussion, the goal is to remove them from the field of play and from the chaos of the game circumstance and to move them to an area that's quiet. And the Madden rule that was popularized by John Madden a couple years ago states that any athlete who has been diagnosed with a concussion must be removed from the field of play entirely. And so in some instances, when I've assessed an athlete and felt them to have a concussion, I will then have to stay back in the locker room and keep an eye on them because they now have to be away from the field, and that's been put into play in terms of how we manage concussions. An athlete who has been deemed to have a concussion must continue to be followed up, or anybody who's suspected of having a concussion, you want to continue keeping an eye on them because sometimes their cognitive status can deteriorate with time. Ultimately, it's important to do follow-up testing, and in order to be returned to play, those athletes have to undergo neuropsychologic testing. There's a battery of tests performed by specialists who do that type of testing, and a neurosurgical follow-up, and ultimately the head team physician has to clear that athlete to return to play. So this is a concussion assessment tool. That's a very busy slide, but that's exactly the tool that we use on the sidelines in the NFL to manage concussion. Each of the boxes serves as a different type of tests. I'm going to boil that down a little bit to give you some highlights. One of the boxes essentially is a series of go or no-go symptoms. Essentially, if an athlete has lost consciousness, if they seem to have deteriorating status, if they seem confused, there's a variety of other topics in that particular box, but some of those things are absolute no-goes. Once they have lost consciousness, they're pulled immediately. There's a variety of tests that test for their orientation, their ability to understand where they are, their balance, as well as their ability to recall tasks or words immediately, as well as in a delayed fashion. Ultimately, they also have to perform a symptom checklist and disclose any symptoms that they may be having. So what are the absolutes here? Well, for any individual who's been diagnosed with a concussion, there is absolutely no return to play on the same day that they were diagnosed. And once they've been removed from a game or practice, that player should not be considered for return to football activities until a series of sequences and clearances have been done. They have to be fully asymptomatic at rest. They also have to be symptomatic asymptomatic with exertion. So once they've passed being fully asymptomatic and having no problems at rest, they need to be that way with exertion as well. They have to have a normal neurologic exam and normal testing for neuropsychologic purposes. They ultimately also have to be cleared by a neurologic consultant who's independent, as well as a team physician. And for any individual who along the way raises concern that they may have more going on, like a brain bleed, we typically and always perform imaging on those individuals. So I wanted to play one more video. This is involving an athlete who suffered a concussion in college. This is a 2010 first-round NFL pick. He suffered 4 concussions late in college and through his first couple years in the NFL, and he is now deemed not clearable. The reason I wanted to show you this video, which I'll play now, is to show you the pose that he has when he comes down. So this is frightening. You can see him right here with his arms extended and his wrists flexed. That is called the decerebrate position. This is a sign of catastrophic brain or cerebral or spine injury. And it may appear at first glance that this is somebody who's got their arms out in celebration or something else, but the fact of the matter is that's a devastating concussion. This was his first of 4 concussions. Somebody invested in the NFL in this individual as a high-level draft pick, and unfortunately, he's been unable to clear in order to return to sport. So you can see this is a scary thing to keep an eye out on the sport. I'm always worried about this when I'm out there. So a quick word on chronic traumatic encephalopathy. Chronic traumatic encephalopathy has become into increasing prominence in the NFL circles as well as in collegiate circles, and is a form of degenerative brain disease that's increasingly been identified in athletes with repetitive blows to the head. Obviously, that occurs in football as well as in some other sports. What we are seeing is athletes who present with a picture of memory loss, aggression and confusion, as well as depression and possibly poor judgment, and appear to demonstrate signs of early dementia. This is a diagnosis that's actually currently being made in autopsy, where individuals are characterized as having autopsies of their brain that show accumulations of something called tau protein. They also have other characteristic findings of atrophy of the brain. The cerebral hemispheres, as well as some of the lower parts of the brain, are atrophied and abnormal, and this tau protein has accumulated in their brain, and that defines the disease at this time. Ultimately, we'd like to be able to identify the disease before autopsy, obviously, and try to curb symptoms before individuals suffer more progressive symptoms. One of the challenges of chronic traumatic encephalopathy is that symptoms often present well after an NFL career has concluded. And so there's a lot of concern in the media and amongst players that this is something that they may suffer from. Yet you're faced with athletes who, when they actually are suffering these injuries, want to return to play as soon as possible. So there's a lot of challenges. We have to be increasingly cautious about our management and try to identify ways to tease this out a little bit better. So those challenges, as I mentioned, the athlete's reluctance to disclose and their desire to play at all costs comes into play here again. One of the challenges is to try to understand a cumulative effect, and one of the outcomes of that cumulative effect is chronic traumatic encephalopathy. It may be easy to clear somebody who's had their first concussion, but what about if they've had their fourth or fifth concussion in their career? At what point do you draw the line and just say it's not worth playing anymore? So I think what we need to do is research this better to better understand what's going on from a long-term effect standpoint as well as from a short-term effect standpoint. So that is it.
We have a few minutes before we're going to give you your break, so why don't we have people come and ask questions, and don't forget to use the microphones in the aisle if you would. Okay, while we're waiting, I have a question.
Sure.
Soccer.
Yes.
My sons play soccer and they bounce that ball on their heads. I just think that's gotta hurt.
Well, there are studies out there that show that the possibility of accumulating similar changes to the brains that we see in chronic traumatic encephalopathy with subconcussive blows. I think the fact of the matter is we don't really know if having many, many headers in a career can contribute to that similar presentation. What we do know is that soccer is another sport where concussion is fairly common, and you have to be aware of the same challenges that I'm aware of for football athletes.
Hi. My grandson plays football and basketball, but mainly football. And I don't understand why the AAU does not support as much training when it comes to the coaches and the coaches speaking to the children about brain injuries and concussions and stuff. I mean, we're lucky he's been playing on some very good teams. I've been in the medical center for a long time. My daughter's a medical assistant, so we keep a real close eye on these kids. But there is never a team doctor around. There is never anybody with any medical training except for the few of us who just happen to be in related. Do you think that needs to be more regulations for the AAU and for the children?
Yeah, I mean,
Even in high school, really.
Yeah, obviously I think high school is probably the largest target. It's where we can affect the most change. There is actually a lot of legal discussion and enforcement that has gone on to try to improve concussion management out in the community. In Washington, Dr. Stan Herring, who's one of our physicians at the University of Washington and our concussion expert for the Seahawks and other sports, has put into effect the LISTET law. I don't know how many of you guys are aware of that law, but that law essentially stipulates that any individual who's a high school player who's been suspected of having a concussion or is diagnosed as having a concussion, be it by their trainer or their coach, needs to be cleared to return to play by a medical professional, ideally a physician or somebody skilled at that assessment. And so the idea is that you're trying to get your athletes who you're concerned about to a physician ultimately to make that judgment, because that person probably has the best knowledge about how to clear or not clear an individual. Now you address, well, what happens on the field, like when an individual has suffered a concussion and may not even be recognized? I think it's our job as a community and physicians and communities to go out and try to educate coaches and various staff to understand the concerns and risks of concussion and to be more cautious about it. I think the media is doing an increasing amount of coverage, so people are more aware of the issue. And there are reports out there that there are less and less people going into football, partly because of that risk of concussion. And so it's hard to say how it's going to play out ultimately, but I think it is something that's in play. But from a litigation standpoint, from a legal standpoint, there are increasing efforts on that front to try to protect our kids.
We've got time for two more questions, this one and then this one.
Can't see you here. I enjoyed your talk. I have a two-part question, if that doesn't count as two questions. But the first one is that it sounds like you say there's very poor evidence for the actual enhancing performance-enhancing drugs. But of what, and many people are mostly interested, not about all the side effects you're talking about or the safety issues, but the unfair advantage. Yeah. So have there been studies in in individuals where you look at, let's say, some sort of endpoint like strength or lifting before, during, and then after to see what the percentage of enhancement is?
Those studies do exist, but in very limited populations. So in terms of trying to define quality of study, you have to design it based on study methodology. And so there are studies looking at small groups of individuals, like 5 to 10 individuals, who get on a treadmill and you exercise them to their maximum aerobic capacity, or you check how much they can lift, and do that before, during, and after use. And you do see some changes in some parameters, but in most of those parameters where you're testing for, like, say, aerobic capacity, there's not that much difference, at least when
In
those
terms
substances.
of anabolic steroids, what's the percent advantage you're seeing, roughly, range?
Well, the steroid issue has been mainly studied in animal studies, mainly because of the stigma that's been associated with the use of that in human studies. So the human studies, to be honest, are really not that, they're very few. They're often not even done in the US, and they just are of such poor quality that it's hard even to kind of gauge any meaningful outcome. The other issue is that the studies are done using methodologies that the users in the community are not actually employing. So they're using even higher doses of steroids, and they're mixing them with growth hormone and all these other substances like insulin and thyroid. It makes the matter far more complicated. So in the way that the substances are being used, they essentially have not been studied in a rigorous way.
Okay, and I'll pass on my second question then.
Okay, how about on a very practical level, what are some specific things that you would advise parents or grandparents to watch out for? And also, do you have any particular ways that you have worked with some of your patients that have been good at opening the dialogue and having discussion?
Yeah, I
Thank
mean,
you.
yeah, absolutely. I think that in terms of things to look out for, some of it is simply just looking for side effects or changes in body composition. So if you see your grandson or son or daughter dramatically change in physical appearance, if they start, for example, if a male starts to develop a breast tissue, gynecomastia is the medical term, that is a side effect that is concerning. Oftentimes, acne accompanies the use of steroids. It very much depends on the type of steroid that's being used, and some steroids have a larger side effect profile, others don't. For example, Winstrol, which is a common oral steroid and is used more for those cutting cycles, tends to have a lot less side effects than Nandrolone, which is a more bulking agent. And so it just depends on what people are using. But I think looking for some of the changes that I talked about, some of the side effects, are the things that are best to look out for. In terms of the discussion with patients, that is a challenging topic. I've seen individuals who've come in having injured themselves in a profound way. I recently saw an individual who had ruptured a muscle in a way that was kind of unusual. And so I just said, hey, in order to kind of understand what's going on, I gotta know if you have been using steroids, because in this particular instance, when your muscle outperforms your tendon, guess what's gonna go? Your tendon. So I just say, I'm not here to judge you, I just kind of have to understand what's going on and why it might be going on. And so I have that discussion. Oftentimes individuals who are using it are appreciative of that kind of discussion. The other thing I try to do is, like I said, I try not to pass judgment. I also try to use some of the language techniques. I'm going to say, are you in a bulking cycle? Are you on a stacking cycle? Is there anything else you're using? Using insulin, using HCG, and so when they start hearing that, they sort of say, oh wow, this guy actually knows what he's talking about, even though I don't know everything that in the way that they do. At least it gives them a clue that I've at least looked into it. So.
All right. Thank you so much.